just look at, well, it's just a conversation between you and Josh.
Sure, yeah. My name is Dr. David Ferreira. I'm a cardiology fellow at John Hunter Hospital in Newcastle, Australia. I would suggest that probably most centres would follow current anaesthetic guidelines, which is recommending fasting before procedures that require routine sedation. I know there are a handful of centres that have already actually removed fasting requirements. However, most centres, including ours, would normally practice normal fasting according to anaesthetic guidelines. The evidence for this is pretty sparse to promote fasting, particularly for procedures that require procedural sedation. In fact, there's a complete absence of evidence that supports that practice. This is a bread and butter cardiology issue. Millions of patients around the world get coronary and device-related procedures every year. So the peri-procedural management of these patients is incredibly important. And there was a recent publication in abstract form called the Chow Now trial, which really stimulated our interest. A non-inferiority trial which confirmed non-inferiority for these sorts of procedures. And so we want to design a study similar to that to also assess for non-inferiority in a multi-centre design. The SCOFF trial was a multi-centre randomised control trial based in Australia, where we randomised patients 1-to-1 to fasting as recommended by anaesthetic guidelines, or no fasting where fasting requirements were completely removed and patients were encouraged to have their regular meals. We had a Bayesian approach to the analysis given the prior data that we had available, and we were looking for non-inferiority first and superiority thereafter. And in total, we estimated a power of 80% if we randomised 600 patients. So we aimed to randomise 600 coronary procedures and 100 device-related procedures, and at the end we randomised 716 patients. And we had a primary composite outcome of aspiration pneumonia, hypotension, hyperglycemia and hypoglycemia. And I guess the primary outcome results were that the event rate for the primary composite outcome was 19.1% in the fasting arm and 12.0% in the no fasting arm. And that absolute difference of 7.1% was a number needed to treat of just over 14. And so that result met both non-inferiority with a probability of non-inferiority of greater than 99.5%. and a probability of superiority of 99.1%. We also looked at patient satisfaction, and patient satisfaction scores were significantly better in the no fasting arm as well. I think when you step back and you have a look at the entirety of the data, thankfully the SCOFF trial does not stand alone. We have the Chow Now trial, but we also have the TONIC trial recently published, the FAST CID trial, Healthy Heart trials, single center randomized trials, including ours, all which show a consistent result that removing fasting requirements does not appear to be associated with adverse patient events, and also appears to be associated with improved patient satisfaction. So I think with the entirety of the data, obviously it'll be up to the cardiology community to decide, but I would suggest the evidence now pushes us away from recommending fasting prior to these sorts of procedures. Further data is always useful. What we have done is we've reached out to other trialists in this area, and we're looking to try to perform an individual patient level meta-analysis where we combine all patient data to get more precise results.